Just go on with some thoughts on the cerebellum and vertigo and dizziness, and we can discuss afterwards your question concerning the other central lesions. So that's what Professor Kim already has shown you. The cerebellum is a quite complicated organ, and I think there is nobody on earth who understands it completely. So we don't have either. But we know that certain regions in the cerebellum are very important in the context of vestibular or oculomotor control. And actually the most important may be the flocculus, as you heard before. It may be the nodulus or even the tonsil, which can be involved. And another major issue is the superior vermis, where you get control of saccadic movements, for example. So if you got lesions in this region, you may detect some certain clinical signs. For example, for the lesion of the upper vermis, you get dysmetric saccades. Or for the lesion of the nodulus, as you have heard before, you may get some central positional nystagmus or some periodic alternating nystagmus. And for the lesion of the flocculus, you get a bunch of things: smooth pursuit, VOR suppression, downbeat nystagmus, so a lot of different symptoms may be possible. So that's the theoretic background on this talk on the cerebellum. So I will show you now a case of a patient. She's 20 years old and she has progressive postural imbalance. That's been a condition which evolved over 5 years' time. So there's nothing acute on it. It's a chronic disorder. And that's how she presented. I hope that the video runs. It did not before, but I then will show you what can be the case. Sorry for that. So what you will see is that she had some downbeating of the eyes in the normal position, and it increased even on a lateral gaze and on a downward gaze condition. And you can actually, by these IC cam, document how the patient feels by subjective view, because what the patient feels is oscillopia. All of the room is just kind of jumping up and down. And of course, this can be reported off as just dizziness or some insecurity walking. So that's one animation which shows you the regular pattern of eye beating in downbeat nystagmus. That's by Dominik Straumann from Zurich. And you see the clinical hallmark of downbeat nystagmus is that you got a downbeat in every direction of gaze, but it changes a little bit with the position of the eyes. So it may be only subtle in the normal gaze position, and it increases in the lateral and downward, and it gets a little less in the upper condition. So because this is, you have to really examine the patient in different eye positions. Because if you have only a very subtle downbeat nystagmus, you may oversee it just looking at the primary gaze position. It may be very subtle and you only catch it if you look to the lateral side. So why do we worry about downbeat nystagmus? We worry about it because it's the most frequent type of nystagmus, of fixation nystagmus, and it does not compensate. So it's a lifelong condition. If you have it, there is no way of going away the symptoms just by its own. And if you look at this consecutive about 4,000 patients, we listed up the most frequent central nystagmus presentations by frequency. You see that about 50% of all central nystagmus presentations are downbeat nystagmus. Another about 25% are upbeat nystagmus. And the good thing on upbeat nystagmus is it goes away. You don't have to worry. It most of the time goes away. The third most is central positional nystagmus, and there are some rare forms which you don't have to bother about. So we care about downbeat nystagmus because it's so frequent. And it's even more frequent in the elderly. It's frequent in people with some neurodegenerative disorders. So you should know what to do in this case. Concerning pathophysiology, there's been some evidence from imaging studies that in these patients you get a hypofunction of the bilateral flocculus. And from that you get a drift of the eyes to the upward position and some voluntary saccadic correction downwards, which makes up then a downbeat nystagmus. So we think that it all happens in these circuits. And don't bother, it's really complicated. But what can give you a downbeat nystagmus is a floccular lesion or degeneration, or rarely some disconnection of the projection from the flocculus to the vestibular nuclei, or very rarely a lesion of the superior vermis, which then gives normally a positional downbeat nystagmus. What do we do about it? So we still have another application for the imipyridines. So as you heard, the imipyridines are a drug which act on the excitability of Purkinje cells. So in downbeat nystagmus, you have a hypofunction of your Purkinje cells in the flocculus. So what you can do is just try to increase the excitability of your floccular Purkinje cells. And that's shown here. You see, this is the condition of a downbeat nystagmus before treating. And this is a condition 30 minutes after giving 20 milligrams of 3,4-D-aminopyridine. And what you can readily see is that the slow phase of your downbeat nystagmus decreases a lot, and this also translates to some subjective improvement of your visual system, of your visual dynamic acuity, and also of your postural stability. So it's been tested for in randomized studies, and this is the latest one from 2013. This is 4-aminopyridine, and they tested 27 patients in a double-blinded crossover study design, and it definitely was shown that the slow phase velocity of downbeat nystagmus decreases with the 4-aminopyridine, but yes, you only have a response rate of about 60%. So you never know if your patient really reacts to it or if not. So you have to try. And what we actually do is that while giving it for the first time, we let them come in as a day clinic patient. We do an ECG to rule out that there's some cardiac arrhythmias. Then you give the 4-aminopyridine and you follow the course and you record the nystagmus quite 1 hour after and compare to the condition before. Then you can see if there is a subjective or objective response to it. And we do another ECG on 4AP to see that there is no cardiac side effects on it. What are the predictors? We know from a recent brain paper of our group that if you have a lesion, if you really have a damage in your cerebellum, say by a tumor, by a bleeding or an ischemia, that the response will be worse. So if you have a normal MRI, it will be better. If you have some vast atrophy of your flocculus, it may be a little worse. Still, I think it's worth trying in these patients because you don't have any other option to help them. Of course, you can do physical therapy, but it is only of minor effect. So really try this. It may work for your patients. Again, the principle will be that you increase your firing rate in the flocculus. And this, again, is an imaging study showing that after administration of 4-aminopyridine, the metabolism of the flocculus goes up as opposed to the condition before. So this is also some proof of principle that it really works in the floccular system and by that increases the function of the flocculus. Some other breaking news. So about 5 years ago, we were just using the 4-aminopyridine, and it worked quite well. But there may be some other drugs who have similar modes of action. For example, the so-called chlorhexoxazone. Chlorhexoxazone is a small calcium-dependent potassium channel activator, and theoretically it should do the same thing than 4-aminopyridine. It should increase the excitability of the vestibular floccular neurons. And actually that could be shown in this study in Neurology 2013, that while giving the chlorhexoxetone in a dose-dependent manner, the downbeat nystagmus decreases. And it also translates into some subjective and objective improvement of postural stability. So we now do have an alternative treatment option in case the 4-aminopyridine does not work properly. You can also try chlorhexoxetone, which is a similar principle. Okay, once that we are now on the drugs and the cerebellum, I will give you another breaking news on the symptomatic treatment of cerebellar ataxia. So, as you know, some patients with cerebellar ataxia will tell you that they are dizzy, that they are unstable, and that they have problems walking. So it may be that these patients come to your balance clinic and they don't have any vestibular but only cerebellar problems. And in this case, we don't have a good idea how to treat them. So we do physiotherapy, and of course it is very important, but there is no established drug agent how to improve their symptoms. And it's been some observation of the last year. It came actually out of the animal experiment. The agent is called tanganil. It's a branched amino acid, and it's called acetyl D-L-leucine. It's sold in France for decades. It's used there for treating vestibular disorders, and you can get it by the International Pharmacy from France. So this is the chemical configuration. And what we saw actually in an experiment with animals after labyrinthitis is that it increases the cerebellar metabolism. It binds to the cerebellum and it increases the metabolism. So from that, a small study has been carried out which just looked at the effects of this symptomatic treatment in patients with cerebellar ataxia. And I'll show you two videos. They're actually in Austrian, right? So you don't have to care. But just look or listen very closely on how the articulation of the patient is. So let's start with this.
Ein Lastwagen voll Winkelgranulat ist in der Nacht auf Freitag auf dem Autobahnring umgekippt. Das Material verteilte sich bei Hohenbrunn über 3 Fahrstreifen.
So even if you don't talk Austrian, that's not normal, right? So this is severely dysarthric. She has real problems with vocalization, and she has problems articulating. And this is after 1 hour of tanganil.
Ein Lastwagen voll Windelgranulat ist in der Nacht auf Freitag auf dem Autobahnring umgekippt. Das Material verteilte sich bei Hohenbrunn über 3 Fahrstreifen der Autobahn.
Okay, she's much faster. Of course, she's doing easier just articulating. And this is one of the major effects that the tanganil can have in these patients, that it increases the fluency and it increases the motor skills and it decreases ataxia. So it's been also proven with some other motor tests like the walking test or the 9-peg-hole test. And I just don't want to bother you too much, but it has been recently reported in the Journal of Neurology in a case series that the patients with this cerebellar ataxia had some significant reduction of their cerebellar severity scores on medication. So we don't know if this is a general principle. It is not a controlled study yet, but a controlled study will just go starting at the beginning of next year, and it will be a multi-center study on different cerebellar ataxia centers in Germany and whole Europe. So we hope that we will have a new principle also for patients who don't have some oculomotor, but mostly postural and gait symptoms from cerebellar disease. But it's not yet proven, so we have to wait the prospective studies. So just to end with this kind of section, I want to show you another patient history. And she's a teacher and presented actually to our outpatient clinic with recurrent attacks of rotatory vertigo. And what she was saying, it ever appeared when she changed position. So she was lying in bed, she was turning around, or she was standing up, and she would get some vertigo, and it would last for 30 to 60 seconds. Okay, easy stuff, right? So it's done. It's benign paroxysmal vertigo. You don't have to bother. So yes, of course, we first thought it should be just be PPV. You know, this would be the most reasonable explanation. But then we examined the patient thoroughly, and you see here the position maneuvers for the Morse maneuver, and just look very, very exact to the position the eyes are beating. So this is now some left side Morse maneuver, and you see with some latency and nystagmus which comes up, but it beats more to downwards, right? And if you wait some time, it will get less, and it even ceases. And that's what the patient also will report, that it is a transient feeling of vertigo or dizziness. See, it stops within 1 minute. And if you do the smooth maneuver on the other side, still with some latency of seconds, you will again have some more subtle, predominantly downbeating nystagmus. And if you want to even challenge her more, you do a head-hanging position, which should be the most provocative maneuver. And yes, again, you see in relation to her head axis, it's a downbeating nystagmus. And of course, there is no way of getting a pure downbeating nystagmus from an inner ear lesion. So based on this clinical exam, we have to suspect that there is a central lesion. And actually, that's the case. Though she showed this small lesion here in the superior vermal region, which actually had been some glioma, and this induced these symptoms. So similarly, what we have to take from this case is that if still the history is very typical for BPPV, we have to do a thorough examination. And if the beating direction of the eyes is not according with the position of the semicircular canal, it is a central problem. And you see there have been a lot of different opinions on this. So there have been papers saying if it starts with some latency, it's peripheral. That's not. It's more often peripheral, but it's not 100% criterion. Or these papers say if it stops by its own, it's peripheral. The central lesion should not stop by its own. That's not 100% right. So please, the most and only clear sign for it is that you exactly match the direction of your eye beating with the direction of the semicircular canal, yes or no. This is actually what makes the difference. And we saw that from Professor Kim also, that these central positional nystagmus forms can be very variable, but they don't fit the semicircular canal. So again, you see we have one favorite drug, which is 4-aminopyridine, but actually it still works also in this case. Because if you heard formerly, we use it for downbeat nystagmus, but you can also use it for positional downbeat nystagmus because we have a similar pathophysiological endpoint. And you saw here, while administering the 4-aminopyridine, we again got some increase of metabolism in the nodular and the parafloccular region. And what the patient actually reported is that on 4-aminopyridine, she has no attacks anymore, nothing. She can work again as a teacher. She's not hindered. She has a good quality of life. We once stopped this for a few weeks and it came again. So it's just a symptomatic treatment for patients with some central positional nystagmus, at least if it's in a downbeating direction. So let me summarize. I think the summary of both of these talks on central lesion could be that it is very important to differentiate central from peripheral forms of vestibular vertigo, and that the most important signs may be the central oculomotor dysfunctional signs, which you can pick up by a thorough examination, that you have to examine the nystagmus as well in a spontaneous, in a fixation, and in a positioning maneuver, and you can add also by doing the head shaking nystagmus to diagnostic accuracy. You should very much look for deficits of vestibular ocular reflex, and maybe the future will be that we do it regularly with the video hit tests because they are more sensitive as opposed to the clinical head impulse test. And finally, you should be very careful to pick up some signs of so-called ocular tilt direction, especially the so-called skew deviation, the vertical deviation of the eyes. Just for a perspective, I think we have some new principles which we can apply also in terms of medication for the central forms of vestibular disorders. For vestibular migraine, the current advice would be to treat with metoprolol at a dose from up to 95 milligram per day. That's at least the dose we use in this prospective controlled trial. It's still an individual treatment trial because we don't have data from prospective studies. For the episodic ataxia type 2, which is a rare diagnosis, the 4-aminopyridine or the 4-aminopyridine slow release form will work, and it makes a lot of difference for the patients. For the cerebellar gate ataxia, the slow release form of 4-aminopyridine may be an option. And maybe in the future days for cerebellar ataxia, we will have another principle, which is the tanganile, to improve the motoric and postural conditions in these patients. So thank you very much for your attention, and I look very much forward to discussing all of those things with you.
Please take a seat here. Professor Kim, please.